Welcome everybody. So I'm Dr. Bev Oates. I'm the National Clinical Lead for Gastroenterology for the Getting It Right First Time project. And welcome to this webinar to launch our National Specialty Report for Gastroenterology. So just to recap for you what we're going to do to start with, we're going to have a welcome from our Chair of GIRFT, our head honcho, Professor Tim Briggs. And then we will have a presentation from our President of the British Society of Gastroenterology, Dr. Alistair McKinley. And then I'll do a talk for you just to give you some key findings and recommendations from the national report. And then what we hope to do is go into a panel discussion, and we've asked some of our main charities to come and join us for this panel discussion to be our patient voice, our representatives. So Julie Thompson from Guts UK, Ruth Wakeman from Crohn's Colitis UK, and Vanessa Hebditch from the British Liver Trust. So without further ado, I want to welcome and introduce Professor Tim Briggs, CBE, who's the National Director of the Clinical Improvement for the NHS, and he's Chair of GIRFT. He's the founder and leader of our GIRFT programme. And we're really so grateful for his vision and support in enabling this programme to be rolled out into so many specialties, including our own in gastroenterology. So welcome, Professor Briggs.
So Bev, thank you very much for those kind opening comments. It's great for me to be able to start the webinar really, and where Bev is going to share the findings and recommendations of this GIRFT National Report for Gastroenterology. So as people may or may not know, GIRFT is a clinically led program using data which allows us to drive change. It started in orthopedics and that has from then developed into 41 specialties, and we've now published 31 national reports, and the medical ones are now coming thick and fast. This report, I feel, comes at a critical time as we're recovering from COVID, and we will need to do things differently. We'll need to use our workforce differently and do things in a different way if we're to provide timely care for all our patients. So I believe that the recommendations within this report have even greater significance and will allow us to achieve this. I want to thank Bev for all her hard work. She's done 129 face-to-face or virtual meetings because COVID came along during that time. She applied the GIRFT principles to her specialty, which includes the digestive tract, liver, biliary system, and pancreas. And I think that, and I went on one of these visits, the huge engagement of the visits, and they've been well received by the profession and senior clinicians. For me, the recommendations are very powerful. What we do with the workforce, how we use them, how we use senior decision makers. And I think the piece around the hepatology is also very useful, especially as this condition affects some of the poorest, most vulnerable people in our society. And we know that 90% of liver disease is attributable to preventable causes. And we've seen a huge rise in premature deaths in patients with this condition of those over 65. So I would like to congratulate Bev and thank her for all her hard work. She certainly has come up to the GIRFT standard in many, many ways. It's been a really privilege to work with her, and I think we've had a great leader, and I think you'll find the report very useful. The recommendations are very powerful, and I think she's got the support from both clinicians and patients. So thanks, Bev, for all your hard work.
Thanks so much, Professor Briggs. That's really kind of you. Just to mention, thank you everybody for joining the webinar. We are recording this webinar and we're going to take questions at the end in the panel discussion. So please put any questions into the Q&A box so that we can pick them up during the panel discussion. So I'm now going to go on and welcome Dr. Alistair McKinley, who's the President of the British Society of Gastroenterology. He's working as a consultant gastroenterologist in Aberdeen, so in Scotland, and out of our reach for the GIRFT programme, which covers England. So I'm really grateful for the support of Alistair and the BSG in helping trying to drive these recommendations across the border. So thank you very much, Alistair, and welcome.
Thank you very much, Bev. Can I just check that people are seeing that first slide? Okay, good. So it's a great pleasure to respond on behalf of the BSG to the publication of the GIRFT report. When I was thinking about this and the situation before the GIRFT process started, I came to mind the American humorist Garrison Keillor, who invented a completely fictitious town called Lake Wobegon. Now, the thing about Lake Wobegon is that it is rooted forever somewhere between 1950 and about 1980. It's very comfortable, it's as American as apple pie, and it's described as a little town that time forgot and the decades cannot improve. And that is a double-edged statement, because on the one hand, it's a nice place to live and it's comfortable. On the other hand, it is very satisfied with itself, and by definition, it makes no progress. And the town motto, ubi quid ubi, which translates as we're here, where are we, would actually very well sum up the situation before GIRFT. You can't really know where you are unless you have some data and some referencing points to put yourself on the map. And the final strap line that he ends every program with is that Lake Wobegon is the place where all the women are strong, all the men are good looking, and all of the children are above average, which of course is a statistical impossibility and has led some psychologists to describe the Wobegon effect, which is the human tendency to overestimate one's achievements and capabilities in relation to others. And the great thing about GIRFT is that it is evidence and data driven, so that at least we know where we stand, and we also then have a marker to move forward. So how does the BSG respond to GIRFT? Well, firstly, we welcome it unreservedly. We're very excited by the opportunities it presents, and we're delighted that it was led from within the gastroenterology community by Bev Oates. We think it's timely, we think it's very comprehensive, and it's constructive. And I think it acts as a really good place to start benchmarking from. And I think the other thing that runs through GIRFT, and it may be that this comes from Tim himself, is that it's been set up not as a league table. This is not Premier Division where you look at where you are on the league table and then try and bring down those at the top. This is where you look at where you are and then use best practice to be constructive and to improve services for all of our patients. And finally, we believe it's very transferable. I wish that we had GIRFT north of the border. So in God we trust, everybody else bring data, and this is evidenced and it's data driven, and that's its power. But it's not always comfortable reading, and I think Bev may allude to this. There is, for example, a huge variation in waiting times up and down the country. There's a big variation in the number of consultants, specialist nurses, and specialist services that are available to our patients. And whenever you read it, you can always look at your own practice and think, we can do better. But there's also some clean washing. The availability of advanced hepatology was very limited 10 years ago, and it's grown significantly, thank goodness. But we want to be in a situation where all patients in the country have the same access to hepatology expertise. And for me personally, the inclusion of nutrition services by Bev and the team was a huge step forward. We are the Cinderella. We provide services across hospitals, so to be included in it was just great. So what have we done at the BSG? Well, first of all, we've been very positive and proactive. We established a GIRFT working group, and that was so that we could anticipate some of the questions that might come out of GIRFT. In particular, I think Bev will allude to pathways, plan on a page. We want to be up there and leading on that. And we've made that GIRFT group 4 nations because we think the data is transferable. So we have representation from Scotland, Wales, and Ireland, in addition to England. One has to say that COVID has not been good for many specialties, but particularly for gastroenterology. So there's been a huge sequestration of GI resources to general medicine. And this is not at the front door, making sure that GI patients are looked after. This is looking after general medical patients on GI wards. Now, we all accept the absolute imperative for that during the COVID pandemic. But if we're going to get back to getting diagnostics and specialist treatment services on track, then we need to step people back into their normal jobs. And what I would be saying to commissioners and managers throughout NHS England is that gastroenterologists have a particular difficulty of being torn three ways. We have a lot of ward work, which is with very ill patients, liver patients particularly, immensely unstable, inflammatory bowel disease, highly specialized. We have a big outpatient load in my hospital, second only to orthopedics. And finally, we're responsible for the vast majority of endoscopy, both diagnostics and therapeutics. And we can only be in one place at one time. So this is a real plea too, to let GI get back on track after COVID. Please also look at the way you step consultants and specialists back into their work as well. So GIRFT is a huge asset that we will embrace. We don't just want all the children to be above average. What we want in gastroenterology is for the average to be so good that wherever you are, wherever you go, and whoever you see, you know that that care will be excellent, timely, and high quality. So a thank you here, first of all, to Tim for the vision and setting this up, and to the GIRFT team for managing to continue with it during the biggest crisis that we've had in the health service since, I suppose, the Second World War. A thank you to NHS England for being bold and imaginative to conceive GIRFT and to push it through. And I really wish it was north of the border. And to Bev, particularly, one of the hardest working women in gastroenterology, and in my view, a GI national treasure. And finally, to Tim and the GIRFT team on this one, we are absolutely all pulling together. Thank you very much indeed.
Thank you so much, Alistair. That's really kind words and certainly definitely sets the scene for us. What I'm going to do now is I'll go on to share my screen so that I can present to you on the national report. Can I just check that that's sharing okay?
Yep.
Okay, so just to give you an outline of what I plan to do, a quick background about developing the data pack and the role of the questionnaire, but also about the impact on the pandemic for our deep dive visits and how that's really influenced this national report. I also want to then pick from the national report some example metrics and some of the recommendations. I obviously can't go through it all in a webinar of this size, but what I want to do is perhaps pick out some of those things that can help with recovery of services and whet your appetite so you're keen to read the rest of the report. And if with time, hopefully just some next steps about what's coming up with GIRFT. So developing the gastro data pack, we've already mentioned that we really do need data, some outcome measures to help improve performance. But gastro, as Alistair's mentioned, is a multi-organ specialty. We're medical and interventional. We've got a number of subspecialty areas. And we also, in most hospitals, also cover some general medicine. So we are pulled in lots of different ways. We can't cover everything in a data pack or a 2-hour deep dive visit. So what I did was liaise with lots of subspecialty colleagues and stakeholders, many of which are on this webinar, but to get ideas about what kind of things people really wanted to see in this kind of data pack, what our priorities were, and then what really was representative available metrics. One of the difficulties is a lot of our outpatient work, there isn't good data sets on outpatient work. So many of the things I would have liked to see in the data pack, I couldn't get in there because we didn't have good national data sets to benchmark. So a lot of the data is on day case and inpatient work rather than outpatient. But what I did was pick some representative metrics across a range of subspecialty areas to be a barometer of service. The other fantastic thing with GIRFT is the that they have. They managed to bring a network, a tapestry of all different data sources and bring them together into one place, into that data pack. And I think that really does give trusts a good idea of their service. The questionnaire, the really useful bit about the questionnaire is that you gather data that isn't available nationally. So when you're deciding on your priorities and some things aren't available in national data sets, often they're things that we asked in the questionnaire. All of the data we used for this national report and all of the questionnaire data is pre-pandemic. It's a level playing field. We did it all at the same time. What we did then was use the data pack data and then the questionnaire data to kind of sense check the data pack as we were doing those visits. And we asked a number of different questions in the the data in the questionnaire to help really get us those extra bits of information. I did also ask in the questionnaire for trusts to tell me their sort of top 5 successes, top 5 challenges and their potential solutions, really to focus their mind and mine for the visit, so we could work out what good ideas we could disseminate and what areas we could perhaps support the trust with. So this is just showing the deep dive visits, and thankfully I had such a fantastic project manager with Lauren Vanderberg that helped organise all of these visits all over the country. We started with face-to-face visits, which was obviously the plan pre-pandemic, and we've done 59 face-to-face visits, thankfully spread all over the country and not in one area. But then the pandemic hit. I think the useful thing for me in terms of the timing of the pandemic was that what we find with GIRFT is when you've done about 40 or 50 visits, you're really clear on a lot of the themes that you're going to want to put in the national report. So I used the time when I couldn't do visits to actually start writing the national report and developing the recommendations. That meant that once we got up and running again and did virtual visits, I could actually go around the country testing those recommendations in the pandemic era and asking trusts, how have they coped? How are they getting the services back on track? What innovation have they seen? What, novel ways of working? So it was actually really helpful to gather information for the data for the national report, but also to help support trusts as we were trying to recover services. So the timing of which to be almost halfway through, I think for me made the national report much more powerful. So I'm just going to show you some of the data from the report. So this is self-reported data from the questionnaire, and this is showing just the variety of sizes of the trusts. So we asked them how many whole-time equivalent gastro consultants they had, how many sort of middle grade specialty registrar, fellows, specialty doctors in gastro, and how many specialist nurses or nurse consultants, and then put the data so we can show just the varying sizes of trusts. We also asked, again, this is all pre-pandemic, what was their waiting times for gastro new patient clinic? And again, a huge variety, some with really short waiting times and others waiting half a year to be seen. And this is pre-pandemic, so actually the waiting times got considerably worse post-pandemic. And we did ask about 7-day services to see if it, does it help or hinder in terms of clinic access. And there's no real correlation between these waits pre-pandemic about whether 7-day working or 7-day services gave you shorter waiting times. Looking at our DNAs or did not attend clinic, this is again national data and showing the main sort of big specialties, and I've highlighted the ones that are perhaps medical based. Gastroenterology and hepatology, which is also in our report, we are one of the highest for DNA rates. It's capacity we can ill afford to lose, and we need to ask ourselves, why do our patients not come? Is our service not set up for their needs? And again, I think the pandemic really helped us look at different ways of working, at virtual consultations, at telephone consultations, video consultations, perhaps even moving towards patient-initiated follow-up. So when they need us, they can see us. So I think this is really important data. We've really got to look as trusts at how we can provide patients what they need and how we can use our capacity to the best of our ability. This is also self-reported data, really looking at endoscopy. We asked the trusts how many endoscopy rooms did the trust have and how many gastrointestinal or GI scopes did they do a year. And if you look at, say, these two examples, this trust here has 5 endoscopy rooms and does 20,000 GI scopes a year. This trust has twice as many endoscopy rooms and does the same amount of GI endoscopy. Now, this isn't the whole story, obviously, looking at a graph like this. So does this trust do more therapeutic work? Are they doing more ERCP or complex polyps? Do they have mothballed rooms? Have they not got the staffing to be able to open all their rooms? Do they do a lot of non-GI scopes, bronchoscopy, cystoscopy, that kind of thing? So it did help, though, discussing with trusts on the visits about productivity and about ways of perhaps being able to have better throughput. So do we need more staff to open more rooms, more flexible timetables to allow backfilling of rooms to make sure we don't leave resource not being used? And do we need to have difficult questions with trusts about If they need to expand GI endoscopy and they're doing a lot of non-GI endoscopy in the unit, do they need to expand and move out perhaps some of the non-GI endoscopy to another perhaps cold site or hub site as things move on? I'm just going to show you other data now looking at specific conditions. So this is looking at acidic drains for patients. So we have patients with liver disease, with cirrhosis, who present with ascites or fluid in the belly where they need to have acidic drains. And in many trusts, almost all of their paracentesis or acidic drains were being done as emergency admissions, whereas other trusts perhaps very proactive at booking patients in for day case paracentesis. And we do know that the best way to recover our services in the end is to try and manage a lot of our emergency admissions. Because if we do reduce emergency admissions and readmissions, we get better patient flow, patients to the right ward to see the right team at the right time, reduced length of stay, and that protects your workforce from being pulled always to cover the front door and the emergencies, when in truth, gastroenterology has a huge outpatient practice, either day case scopes or outpatient clinics, and there we need to try and protect those services as well. So some trusts didn't have many specialist nurses perhaps, or even a day case pathway for paracentesis, and we want to help to disseminate how to do that. This is another way of looking at emergency admissions. This is to do with, again, liver patients with esophageal varices or varicose veins in the gullet. They may bleed and it can be life-threatening. It's an awful condition for patients to have bleeding esophageal varices. It's awful for trusts in that emergency presentation. And some trusts, almost all of the banding of varices they did were being done as emergency admissions, whereas other trusts perhaps were more proactive at being able to manage electively banding varices. So if you're better at screening your cirrhotic population to see if they have varices, patients who've had bleeding perhaps that need then to have a banding program as an outpatient to eradicate those varices to reduce the next emergency presentation effectively. And again, it's looking at your services, at why perhaps patients recurrently present with bleeding rather than us proactively deal with their varices. And this is for inflammatory bowel disease. Again, the majority of what we see with inflammatory bowel disease is outpatient based. And as I mentioned with HES, the data isn't particularly good for outpatients. We can say if you came as a new patient or a follow-up, or if you were discharged at first visit, but we can't often say anything more about what you came with or what the plan was. So for inflammatory bowel disease, what I did was look at, of patients who get admitted, what percentage are admitted as an emergency versus perhaps more elective care. And remember, we have day case admissions for IBD patients having endoscopy procedures or having infusions for things like biologic treatment. So some trusts, you're asking them, why have you got so many emergency admissions? Have you got, how quick is your access to clinic for these patients when they're, are they getting delayed diagnosis and therefore several emergency admissions before the diagnosis is clear? Or how good are your helpline and your flare clinic access so that when patients need us with a flare, we can be proactive. This is just showing, this is endoscopy data, giving a trust an idea of who they're scoping. So flexible sigmoidoscopy, this is women on the left, men on the right. The black line was the England average. So this trust, the conversation we were having pre-pandemic with the trust was, they're doing bowel scope screening. So the 55-year-old patients getting flexible sigmoidoscopy. So we could have a conversation about, is this service outstripping your capacity to provide the flexible sigmoidoscopy to other age groups? In the post-pandemic, in the virtual visits, the conversation I was having with trusts is your workforce that's doing bowel scope, are they only flexi-scope trained? Because actually this service wasn't coming back and isn't coming back, and therefore we need to look at that workforce and expand their training, either say into colonoscopy or gastroscopy or clinic areas or whatever we choose to do, but to make sure we don't lose that specialist service and that specialty workforce from our services. So who are we scoping, but also when are we scoping? So again, this trust I was looking at flexible sigmoidoscopies by day of the week and colonoscopies by day of the week. This is done as, it's a surrogate, because in HES you look at date of admission, not date of test. But the majority of GI endoscopy is day case, so date of admission is date of test. So the blue dots here are the national average, the England average. So with this trust, Monday, Wednesday, Thursday, they were doing bowel scope screening, which is why they have big peaks of flexi-sigs then. But this same trust was then doing a whole host of their colonoscopy on a Saturday. And what I explained to trusts is, if this was an airline, Monday to Friday are your cheap seats, Saturday's business class, Sunday's first class, in terms of how much it costs to put your service on. So really what you want to do is to try and make best use of your weekday resource, of backfilling. We know running more rooms side by side is actually, there's real economies of scale. Often at weekends, we're not running as many rooms. We're often insourcing and paying waiting list initiative or agency rates. We also know with colonoscopy that there is some evidence to suggest perhaps lower polyp detection rates at weekends. That may be a different group of patients that choose weekend lists, but also it may be to do with the workforce as well. And we know that there may be more redo colonoscopy from a weekend list. If we find a big polyp and it's insourced staff or it's on-call facilities at weekends, people are less keen to tackle a big polyp, and that patient may then have to be rebooked to have a procedure during the week. So I think it is having that discussion with trusts. I was also clear with them that actually a lot of weekend working, there's a difference between 7-day services and 7-day working. And gastroenterology, unfortunately, has the highest burnout of any medical specialty. And I think, as Alistair's alluded to, we're pulled in many different ways. But often in terms of capacity, you're relying on people doing overtime and extra lists to provide capacity. What you really need is more staff to truly run a 7-day service rather than 7-day working. So the report's been published. It was submitted actually in November. As I mentioned, we do a lot of the writing of it even before the visits are finished. I did update it slightly in March just to show that all the visits were complete. It is a big document. It's a lot of recommendations and actions, but its primary endpoint is to improve patient care and outcomes. We also know that there are quite significant notional financial opportunities by moving that dial, by improving the average, by getting people to work towards that sort of top decile approach, because actually that will also release income. We know doing the right thing for our patients the first time is the most cost-effective care. So I'm going to show you some of the recommendations now from each of the sort of different areas. So in terms of managing demand, we absolutely showed with the pandemic about the need for senior clinical decision makers for triaging of outpatient referrals and of endoscopy procedures. We can't afford to be doing procedures on patients where it's not the right procedure for them. And we also need to make sure that patients are in the right stream in terms of clinic. And in many times we can advise on the patient's care when we triage the referral, so they're not waiting half a year to be seen, only to be told perhaps they're in the wrong stream. And one of the things here was that the electronic referral system nationally seems to clump GI medicine and GI surgery together. And patients sometimes wait half a year to then be seen in a gastro clinic to find that the referral is from a GP asking for a patient to have a cholecystectomy, removing their gallbladder, and that needs to go to a surgical clinic. And there's nothing more frustrating for patients than to find you've waited ages in the wrong stream to then end up in another queue that you have to wait for again. Looking at another way of optimizing capacity, so it's not just managing the demand, it's also looking at the capacity. I've mentioned about 6- and 7-day services rather than 6- and 7-day working. You need to use your workforce as best you can. So again, seeing how we're managing the direct clinical time of clinicians, looking at things like more flexible timetables, allowing for backfill, having enough staff to truly work a 7-day service. As we've already mentioned, we were absolutely hammered by the pandemic, as many people were, with general physicians as gastroenterologists, so we can and did help with general medicine. But now we really do need to try and consolidate to clear this backlog for our patients that are waiting for clinics and waiting for procedures. And these services don't lead themselves. The other thing is it's really important to ensure in your trust that there is job plan time leading service, because a well-led service is an efficient service for patients and is cost efficient. So looking at endoscopy, one of the things I noticed in some trusts, they didn't have enough emergency access for endoscopy by day. And so the concentration was often on trying to get through the elective lists. And what we can't afford to do is have patients that need emergency endoscopy or inpatient endoscopy having to wait. We really need to move that flow through, because again, we know better flow of patients through the trust will also protect your elective services. And we have made a case for how we need to expand endoscopy nationally, so with things like diagnostic hubs as well. But there are real economies of scale, so my preference really is to expand current units rather than necessarily build small standalone units elsewhere. Again, with endoscopy, it's making sure we're doing the right tests on the right patients. So particularly, there was a change in September 2019 for the surveillance guidance for polyps and post-cancer surveillance, and making sure that trusts are vetting their procedures against new guidance, because actually there's a big chunk of patients that no longer require surveillance, and you don't want to put them through a procedure they don't need, but equally you don't want to use the resource doing procedures where there's other people that are more in need of that too. So making sure that we do vet colonoscopy, that patients are appropriately pre-assessed or given in the right information so that they have prep correctly and that the right people attend for their procedure. We also need to just make sure that they are well enough, and again, making sure that we're assessing for wellness and frailty and deciding, is this the most suitable test for them, or do we need to be expanding sort of non-invasive techniques, CT, CTVC or capsule endoscopy. Liver disease, I've mentioned about a lot of liver disease patients do end up with emergency admissions, and we do need to be good at using things like cirrhosis care bundles to make sure that when the patient attends hospital that we get the care right from the front door, right first time. But also discharge checklists. There's good evidence that if we do make sure that we've dotted the I's and crossed the T's when patients go home, so that we're less likely for them to end up with another emergency admission. So if they've presented with a new presentation of cirrhosis, have we counselled them about the disease? Have we explained why we're going to be doing hepatoma surveillance or screening for varices? Or if they came in with emergency for paracentesis, have we actually tried to then book the next as an elective procedure? I mentioned about with inflammatory bowel disease, the sort of three main priorities here is getting the diagnosis quickly. So ideally, nice guidance is that if you're referred with possible IBD, we should be seeing you in clinic within 4 weeks, because these patients do end up with a number of attendances to A&E or even admissions before their diagnosis is made. We also need to manage flares promptly. Again, we know better control for patients gives them a better quality of life, but it's also cost-effective care. They're less users of resource, less likely to end up needing surgery. And we need every trust to have an acute severe colitis pathway, so that when patients do present with an acute severe colitis, that we're proactive with their management of the inflammation, so that we are less likely to find they end up needing to have their bowel removed. And finally, one other example to show you was about nutrition. We absolutely know that it's key to improving outcomes for patients, that we do identify those patients, particularly those that are malnourished, that we have specialist nurses in every trust. There should be nutrition specialist nurse in every trust, and there isn't when we look around the country. We need to make sure that we've got things like consultant-led nutrition ward rounds, and that we're engaging with networks where needed to sort of help support the nutrition of our patients. So what's next for GIRFT? Well, on the GIRFT website, there is a best practice library, and there's a GIRFT Academy of sort of online learning programs. So we should be able to disseminate good practice to trusts and help them not have to reinvent the wheel, but get ideas from each other. We're looking at having refreshed clinical data going into model hospital, so that trusts can track their progress. Perhaps if you appoint a specialist nurse to be doing your paracentesis as a day case, you'd want to be able to track that kind of data to see if it's reducing your admissions. We're looking at trying to do regional or ICS level visits. So again, encouraging networking, encouraging trust to support and help each other. And we're developing some standardized clinical pathways. Again, I'll show you just an example on here. So I'm not going to go through this, but this is the example of the acidic drain pathway that we've developed. They're going to be like a plan on a page that trusts can then look at that against their own service, check that they are doing the right things, adapt it to their service. And encouraging things like, even when patients present with ascites as an emergency, we can often divert those through into a day case pathway. And we need to make sure that when they then go home from that day case, that we've done all the right things to reduce their next admission. So in summary, GIRF is a data-driven, clinically led national programme to reduce unwarranted variation and improve outcomes. We really must learn from each other and share best practice. Everybody's busy. We can't all be starting from scratch trying to develop this. It's peer-to-peer and shoulder-to-shoulder ethos to get teams and trusts to work together, to get networks. And I'm really grateful to the BSG for trying to get this across into the 4 nations. We can and we must build back better with service recovery from the pandemic. And we know that better, safer patient care and better use of resources that GIRF allows us to do is a definite win-win. So I want to do now, if you have any questions, put them in the Q&A box, because what we're going to do now is to go through into a panel discussion where Alistair and myself are joined by our patient advocates, our charities, Julie, Ruth and Vanessa, so that we can take your questions and hopefully get the report through into business as usual. So thank you very much.
Thank you, Bev. So it's my privilege to chair this session. Let me first of all introduce our other guests. So Julie Thompson is the information manager at Guts UK. Guts UK does a huge amount of patient information work for BSG and for other specialties. Ruth Wakeman is Director of Services, Advocacy and Evidence at Crohn's and Colitis UK. CCUK, a charity that really has pushed standards of care and challenged us to improve standards of care for our patients with inflammatory bowel disease. And finally, Vanessa Hebditch, Director of Communications and Policy at the British Liver Trust. And liver disease has cropped up already during the course of these conversations. Can I also just encourage you to put questions in the Q&A? If I run out of questions to ask the panelists, I will be forced to sing. And this will be etched into your memories for a very long time to come into the future. So for your own personal safety and psychological health, please ask us some questions. But could I just start off, Chairman's privilege, to go to each of our guests, and I'd like to go first of all to Ruth. COVID's had, a huge impact on patients, particularly during lockdown, and accessing medical information, medical opinion has been much more difficult. Could you just describe a little bit about how that's impacted on Guts UK and its work?
Thanks, Alistair. One of our charitable objectives at Guts UK is to provide information for people, and we have an information service that people can access by phone and email. And I will state that this isn't a helpline. We don't advertise a helpline, but many people do find us and they do use us as a helpline. And particularly during the pandemic, we supported many people during this time, and unfortunately, some of those people reported quite severe symptoms, and they did need lots of encouragement to seek urgent help. And our email information requests increased by 65% over that time, and our telephone contacts increased by 100%. This year, our information emails are predicted to reach around 80% of what they did in 2020. But our phone calls, on the other hand, have increased by another 53% up to October this year. And whilst we've had increased demand on our services, we've also lost income during that time. And one of our income streams is we do sell information leaflets to hospitals, and this is just an example of one of those. And during 2020, our income through selling those leaflets dropped by 50%. And we know why that was. That was due to virtual clinics. And virtual clinics are expected to continue as they've got many benefits for patients, and particularly those patients who have severe symptoms and severe diarrhea and worry about travelling to hospital, and those that are vulnerable and immunocompromised. However, it's likely that a range of options hopefully will be offered going forward, because that doesn't suit everyone. And as the GIRFT report mentions, referring patients to appropriate sources of information to support self-management is really important. And patients will search on the internet about their diagnosis if they're not directed to relevant evidence-based content. And at Guts UK, we also support other patients in our community that don't have internet access. So please could I encourage people to ask your patients in your virtual clinics if they use the internet, and direct them to relevant websites so they can access safe information. And Eve.
Sorry, thank you, Julie. I'm going to just move on a little bit.
That's
because
fine.
we've got, but I think the point you're making, which is that if you don't do face-to-face, you can't hand out a leaflet, but it is there online. And I think what we need to make sure is people go to reputable sources rather than just Dr. Google. So I want to come on to Ruth. You know, IBD is, of course, Crohn's and colitis, a chronic set of conditions. And it's had a very major impact on patients with things like shielding and so on during the pandemic. What have you been seeing, and how do you think GIRFT interacts with your experience?
Yes, thank you, Alistair. So I think we'd echo many of the points that Julie made, actually. The pandemic had a really significant impact on people with Crohn's and colitis, you know, impact of shielding. And we know that people face difficulties accessing their IBD team, as members of the IBD team were redeployed. And we also saw a huge rise in people contacting us, and numbers of people looking at our information on the website. I mean, we really welcome the GIRFT report. We support the recommendations in the GIRFT report. And the findings really align with the IBD UK national report that was published earlier this year. So Crohn's and Colitis UK and the BSG, members of IBD UK, a partnership of 17 organisations. And the national report really sets out the variation in care. We had 166 services, 10,000 patients, reported data. And really echoing the presentation that Bev made, people are waiting too long for a diagnosis. They're not able to access specialist care quickly enough. Multidisciplinary teams aren't well resourced, so we need more nurses, more pharmacists, dietitians, psychologists, and so on. And care really isn't joined up between primary and secondary care either. So we really welcome GIRFT, and we'd like to see that it's really effectively resourced and more proactive management of people with IBD.
And the IBD report, there are going up some links into that. And I think the IBD report, in a sense, is a bit like a magnifying glass over it. Yes. Complements GIRFT. So very quickly, I want to come to Vanessa now. Really, I think one of the things that comes out is there's been a growth in hepatology services, but there's been a growth in demand as well. And of course, we know that during lockdown, although the overall consumption of alcohol fell slightly, we know that the 2 quintiles who were already drinking more actually increased their alcohol intake rather than diminishing it. Have you seen an impact in the British Liver Trust? And what do you think the overall message for hepatology within GIRFT is? Vanessa, you're muted.
Sorry. Yeah, like the other charities, lockdown did have a huge impact for us as a charity, and also for the patients that we serve. In the first month of lockdown, calls to the British Liver Trust nurse-led helpline went up by 155%. And, you know, just our COVID pages on the website received over 400,000 unique visitors. Many inquiries do regard alcohol. You mentioned alcohol. So, for example, we've been hearing from people who have increased their drinking during lockdown and are worried, like you mentioned. Others who've had who have an addiction to alcohol and have been discharged from hospital detox, but with no follow-up. We've had people calling who've previously had treatment and have abstained, but are abstaining, have given up alcohol, but sadly due to the pressures, the isolation during COVID, have lapsed, and we're not able to sort of access addiction services or alcohol care teams. So we're really delighted to see the GIRF report, and as we come out of COVID, we hope trust teams will be able to implement the recommendation to improve access to alcohol care teams and community detox programs. But liver disease, as we know, is not just about alcohol, and I really think that many of the recommendations in the report, GIRF report, should, you know, reduce some of the unwarranted variation we see. We were particularly delighted to see the emphasis on the need for secondary care to proactively work with primary care to improve early diagnosis by implementing best practice fibrosis assessment. We've recently conducted research saying huge areas of the UK don't have pathways in place for the early detection, and we regularly hear from patients who've been diagnosed too late. But overall, the key thing that we take from the report is that by working in partnership and also learning about best practice, sharing ideas, we can improve care. And so really hope to be a key part of that mix as the British Liver Trust, and look forward to working closely with clinicians and other stakeholders to implement the recommendations.
Thank you very much, Vanessa. So I'm delighted to tell you that there have been questions coming in now. Obviously, the threat had the necessary effect, but we can still take more questions, and if I still have that threat out there, I will sing unless people come in. Bev, two that I want to come to, and it's a difficult one, and Liz Farrington and another attendee have both really said the same thing. There is a slight discrepancy. The acute medicine GIRF reports talk about getting wider specialty involvement in the acute medicine rota, and we've seen that. Gastroenterologists going to the front line. On the other hand, GIRF is obviously talking about the need for gastroenterologists to do specialty work and the improvement, particularly for things like hepatology and IBD, where actually general physicians don't necessarily have the knowledge base and experience to deal with it. Just very quickly, how do we resolve that discrepancy?
Yeah, it's a really good point. And I think you can do both to some degree. I think we do have a responsibility to try and reduce the presentations of acute admissions. And as a specialty, we can, by being more proactive with our outpatient base, as we've talked about, like day case paracentesis and, you know, a quicker triage of referrals and things. I think also it's trying to have better in reach. So we do know that patients seen by the right specialty first time will have a better flow through the hospital, a shorter length of stay. So I think, you know, we've seen good practice go around the country where some trusts do have very good in reach into A&E and the acute medicine units, seeing the gastro part of the take, as it were, to try and, you know, we're more likely to discharge our own patients, as are other specialties. So I think we have to be better at providing things like hot clinics, alternatives to admission, to try and manage the huge numbers of patients that are presenting to A&E. And I know we've had good practice. I know Wolverhampton have done some really good work with having a sort of day case gastroenterology, you know, unit next to A&E, where if patients present with, you know, anemia, some patients with a very low HB, where they often get admitted and then transfused and then wait for inpatient investigation, whereas actually diverting these kind of patients to day case if they're not acutely bleeding, so that we can transfuse and then put them through rapid outpatient investigation. Same with day case paracentesis. So I do think we have to support the take, absolutely, but we need to work to try and reduce the number of emergency admissions, and that will make the take more manageable.
So I think the other thing, of course, is that this will be often a very local thing, depending on numbers and the structure of the take and so on. But I think we all understand the difficulty that those involved in medical management and in organizing the management side of things face. And I would just add that enhanced senior triage, which is absolutely essential if you're going to move people down the much more complex outpatient options that we have now, it takes a lot of time. It's very expensive in terms of time. And we really have to move that into people's job plans. It is as important as the clinic or the endoscopy list that it's actually triaging. There's I think more of a comment here from Pushpakaram Manaswamy, who just comments that ERS2, which I'm taking as the electronic record, is on the way? And could we make sure that we engage to improve the user interface for the clinical assessment service to triage and provide advice and guidance? And I think that goes very much with what you've just been talking about, making sure that the enhanced senior triage works properly and doesn't have a boundary to general practice. Somebody has asked, GIRF's impact focus on low complexity, high volume. What effects that having on elective inflammatory bowel disease? And what are the opportunities to improve access to timely elective surgery? Now, Ruth, I don't know if you want to comment a little bit about that, accessing surgery from the point of view of IBD patients.
Yes, thank you. We know that it's a real problem. I mean, we heard from someone this week, one of the trusts saying, you know, worst in lifetime memory. Proactive management, avoiding people coming in as emergency cases, ultimately obviously has a massive benefit for patients, but also a huge benefit in terms of costs and NHS time as well. So we really need to make sure that people are getting their elective surgery and that it's not deprioritised and continue to be deprioritised. And I'm sure Bev would probably like to add to that as well.
Yeah, no, I absolutely agree with you. And I think what often happens is patients, when they're delayed, we end up with emergency surgery, which is often more complex, often involves stomas rather than primary anastomosis, that kind of thing. So it is difficult. I appreciate there's lots of competing priorities. I think the key is often networking and teams working together. And sometimes it is just picking up the phone and having discussions with your surgical colleagues. We've seen good practice going around the country of you know, co-locating services so that you can have you know, the GI surgery and GI medicine much more co-located and working much closer together to share patients and to help each other. So I think it really is going to be a lot more networking, a lot more closer collaboration with MDTs, things like that. Thank
you very much. I want to move to Roger Prudhomme has put in 2 questions. So obviously my threat to sing has had a real impact on some people. This one's really interesting. Use of FIT testing. So for those who don't know, that's fecal immunochemical testing, the same test that's used or has been used in Scotland for a long time for bowel cancer screening. He says getting a dig in, but which is coming into England. What's the effect on colonic imaging pathways? And some colleagues, he mentions the area he comes from, are very reluctant to step down lower gastrointestinal investigations on people who have a QFIT less than 10. So I suppose it comes down to how far does one go in excluding people based on perhaps one screening test. Any thoughts, Bev?
I think a lot of change had to happen during the pandemic. And I think the important bit we need is to make sure that with the data that we're able to see the consequences of that. So when we suddenly, you know, at the peak of the pandemic, endoscopy services went down to 5% of activity. We were really just doing the emergency stuff. So there'll be a lot of patients out there that would normally have presented and been diagnosed with a malignancy, let's say, during the pandemic that haven't actually yet presented. So we were left with this massive backlog, and we've had to then start using things to try and prioritise. So using things like FIT testing to highlight those that might be more likely to have cancer, or fecal calprotectin, let's say, for inflammatory bowel disease. So I think it's all part of triage, and I appreciate that the FIT testing is a bit of a different thing in that with the threshold that we use for bowel cancer screening, it's often a very high FIT level that you're looking for before you investigate, whereas for symptomatic patients we're taking a lower FIT test to prioritise them with their symptoms and a positive fecal FIT test. So I think it is difficult, and I think the data is key. We need to follow the consequences of what.
Could I just come in there, Bev, because BSG is in the, along with ACGBI are in the, and forgive me, I've forgotten the name of the radiology section that particularly deals with the abdomen and the gut. It will come back to me in a second, but we're working jointly on a guideline on QFIT testing, Roger. And one slight problem is, I think there's no doubt at the top end, you know, if you have a QFIT greater than 400, your chance of having malignancy is probably about 25%. The real difficulty is this low cutoff. And when we did our first attempt at a guideline, the feeling was the evidence had not quite matured enough to be definitive. So I think there is going to be this period of time when people are not quite sure what to do. And I'm sure it's going to be based on age and likelihood as well, rather than simply a QFIT. Roger's other question, I think, will be echoed by many other people, which is how can commissioning change to incentivize people to plan around improving outcomes rather than simply prioritizing volume going through. So I think perhaps I'd come back to Julie on that. How do we make commissioning concentrate on outcome?
I think outcomes are really, really important for patients, essentially. And, you know, it's looking, I suppose, at improvements in patient symptoms. It's really, I mean, it's what's important to patients are outcomes. You know, they want to see sort of improvements in their GI symptoms. And I'm sure that focusing more on outcomes would actually reduce, for example, patients with IBS will sometimes continue to go and visit their GP. They get referral through some, you know, again, and if we can focus on improving outcomes there, that would reduce the impact on services as well, I think.
Thank you, Julie. There's a really key one coming up here, and I'm trying to summarize a number of people's questions. The first of all is, how do we use GIRF to get additional resource? But this also recognizes that GIRF has looked at 42 other specialties. And if you're in a position as a CEO or a COO trying to put this in perspective, where does gastroenterology fit against 42 other specialties? What can we do to help people with that, particularly if you're perhaps in a smaller DGH where you may not have the capacity to do it all? Bev, I'm going to come back to you on that one, but I'm going to open up to anybody else for suggestion as well.
I think one of the important things is sometimes you're having to use the resources that you already have. You know, a lot of trusts will say, well, look, I haven't got the money to have another specialist nurse, although we can show with the data that actually what usually happens is you end up with a lot more emergency admissions, which is much more expensive. But also getting people to work to the top of their license. That you sometimes find, you know, we went to many places where the inflammatory bowel disease nurses, for example, or the liver specialist nurses were spending a lot of the time having to do sort of administrative tasks that perhaps if they had some administrative support, then they could be seeing more patients while somebody else is booking the appointments or sending out the blood forms, you know, for patients having monitoring of their medication. So I think it is trying to look at what you've got and how to use your staff to the best of their abilities, rather than having things either duplicated or having nurses doing administrative tasks, you know, that kind of thing. So I think that's what I would suggest to trusts is to trying to work together to see how to support the clinicians.
And I think the other thing is you've got to look at what resource you have within a trust, and also see if there's anybody else who can do it. And if the answer is nobody else can really do that, then you need to prioritize towards the specialty service which is offering that. And I think one thing that I would add into that is that there's often a feeling that if you simply in-source or outsource, depending on how you look at it, procedures, for example, you save a lot of potential time. But in my experience and in our members' experience, all those results, and often crucially the management decisions, fall back on the gastroenterologists. And there would actually be a considerable efficiency saving if you deployed gastroenterologists to do the gastroenterology and shorten some of those loops. And it would also get patients diagnosed an awful lot faster too. And I think the other point I would make is that there are some areas, like particularly complex liver disease, and I don't know if Vanessa wants to comment, where I think people are very frightened of it. Other specialists are very frightened. It's a very frightening set of conditions, and it is much better dealt with by people who have a specialty interest. And you could add IBD into that as well, Ruth. Vanessa.
Yeah, I would completely agree. But one of the things that I think the GIRF report highlights is this idea of us working much more closely across different specialties. So, for example, we do need to get A&E involved in looking at the bundle, the care bundle, the bundle that means that people are referred to hepatology services quickly, because at the moment we know that you know, a high percentage of people who their first diagnosis as an emergency admission die within 60 days. So we really need to make sure that we're working across the specialties as well.
So Vanessa, I'm going to have to stop you because we're down to our last 2 minutes and I don't want to let Bev have a chance to speak as well. I think we will get back wherever possible to answer people's questions that have been in the chat line, and I'm beginning to regret the threat about singing because we've had lots of questions flooding in. I think one thing that has come up, Bev, 1 second really to answer it, which is about diagnostic and treatment hubs. In your experience with GIRF, do you think there's value in going for a separate hub, or do you think we should just be concentrating on developing within a hospital? You have 1 minute.
Okay, so I think it depends on the hospital and it depends on the population, because some places are geographically quite spread out, others less so. So I think realistically it's not going to be one size fits all, but there are definitely economies of scale in terms of endoscopy, that running a single room, you know, often you can expand. You know, we were saying to many trusts, if you've got 4 rooms, let's say, going to 5 rooms, you may need somebody extra, obviously 2 nurses in that room and an endoscopist, but you don't necessarily need someone extra in recovery or front reception or decon or discharge. So there are economies of scale. So ideally, I think expanding what we have is preferable. But in some regions, they may be landlocked and require some diagnostic hubs.
So this is, I have to stop, but that's, I mean, it's generated huge interest. I haven't had to sing, for which I'm extremely grateful. And I'd like to thank Julie, Ruth, and Vanessa for being so active as part of the discussion. Bev, over to you.
Thank you very much. And, you know, I will get back to people with the questions. I appreciate we've not been able to get through all the questions in the chat, and we absolutely will try and get back to people with some responses. I really want to say a big thanks to all of you for joining, to all of my panelists, and particularly to project manager Lauren for all the help in sort of getting my GIRF programme for gastro off the ground and running, to all the support from the trust and the teams that we've had in visiting all around the country. It's been just fantastic to see how people have worked together, and I'm really looking forward to us all continuing to work together for the benefit of our patients. So thank you very much. And I'll wish you all a good afternoon for your Friday afternoon and a lovely weekend. Thank you.